Dear friends, in this presentation, we will discuss the impact of COVID-19 pandemic in our day-to-day surgical practice. As we all know, COVID-19 pandemic has created a major disruption in our surgical practice. It has been there for the past 6 months. It is a unprecedented global pandemic, and as a surgical community, we feel the urgent need to consider the safety of all our colleagues, our healthcare personnel during this pandemic, and also still deliver the surgical services to our patients. In this aspect, we have to prioritize our resources, reduce the infection rates to the patients and the healthcare personnel. In the end, we have to be able to achieve the best outcome for the individual patient. So, in this talk, I will discuss on these following heads. What is the impact of COVID-19 in our surgical practice? What is the risk of transmission during surgery? And is there any change in the operation theater setup and protocols? What is the current guidelines on preoperative screening for a patient who is going to undergo a surgical procedure? And is there a change in postoperative monitoring? For this, we have several societies that have come out with guidelines on their own. Most of the guidelines are having overlapping essentials for practice, and several of them are naturally influenced by uh, the pandemic situation in their particular country or in their part of the world. So, the first and foremost impact of COVID-19 on surgical practice is the cancelled elective surgeries. Definitely, we can understand why several hospitals have cancelled the elective surgical list. It prevents the in-hospital viral transmission. It definitely prevents pulmonary complications in patients who have unsuspected COVID-19. It preserves the PPE supplies, the personal protective equipment supplies for the frontline health workers who are taking care of COVID-19 patients in the ICU or in the respiratory wards, and also it releases the ward and critical care beds for managing the surge in the COVID-19 patients. So, data has shown us that up to 60 to 80% of all elective surgeries were cancelled during the peak of COVID-19 pandemic all over the world. So, this has definitely created a lot of hardship for the patients who are waiting for their elective surgeries. So, what is the impact? Even though these surgeries are elective, they are definitely time sensitive, like transplant and cancer surgeries. So, delaying the surgery for these patients is definitely going to delay the diagnosis and further treatment when it comes to cancer and transplant waitlisted patients. And by delaying the surgery, the quality of life is also going to be affected badly, and there can be unnecessary deaths if surgery is not offered early. And overall, from the population point of view, there will be decreased overall health and productivity, resulting in substantial social cost. So, to put this in perspective, a recent study published in the British Journal of Surgery found out that up to 28.4 million surgeries were cancelled globally during the peak 12 weeks of COVID-19 pandemic. This was a study that was spanning around 60 countries, and most importantly, what was found is that it is going to take up to 11 months to clear the waiting list, and it is going to cost up to 2 billion pounds. So you can imagine, if this is the cost in Great Britain alone, what will be the impact on the rest of the world when it comes to surgical practice. Viewers, coming to the next aspect of discussion, what is the impact of COVID-19 in our routine surgical practice when it comes to reorganization of surgical workforce? You might have seen there are several hospitals where surgeons have to do ICU rotations. They have to do fulfill alternate non-surgical roles like we cover for our respiratory medicine colleagues, we cover for our physicians. There are several instances where we do alternate surgical roles. For example, a vascular surgeon can cover for a plastic surgeon. Yeah, a gastrointestinal surgeon can take turns with a general surgeon. So these things are definitely happening. It has increased the camaraderie among the surgical community, and it has definitely brought to light how, as a team, we are responding remarkably well to the pandemic. And during all this time, we as a community have maintained emergency services, emergency surgical services. That is something that is really commendable. And also we have to take note of the fact that our surgical workforce is definitely protected by adhering to the principles of personal protective policies of the hospital. So when it comes to the patient point of view, how it has changed our workplace. So it is absolutely necessary to maintain a COVID cold environment for patients to undergo a safe surgery. So how to maintain a COVID cold environment is not precisely defined as yet. It is slowly getting defined. Whether it includes regular staff and patient testing. Uh, Patient testing is mandatory before they get admitted into the hospital, but staff testing, should we screen the staff routinely? How frequently we have to screen the staff? Uh, Definitely, a staff who is doing surgical duty cannot be placed in a place where they are going to manage the COVID patients. And when we discussed in our liver transplant community, what we found that the staff, the nursing staff are screened routinely for their symptoms. If there are symptoms, if someone is found to be positive, their close contacts are screened. So that is how it is going on at the present moment. Then there should be definitely good bed management and attention to patient flow and footfall. So that is essential, that we need to cordon off the area where we are going to manage the general surgical patients, and it should be physically isolated from patients who are COVID positive. Like it should be in a different building within the hospital complex, or it should be in a different floor. So that is an administrative decision, and I think doctors sitting with the administrators of the hospital should take a decision on that. And allocation of the staff is also an important thing that we should pay attention to it, so that there will be no overlap between the staff nurses and the other healthcare personnel who take care of COVID patients and who take care of non-COVID surgical patients. So coming to risk of COVID-19 transmission during surgery, what are all the ways the surgical community is exposed to COVID-19 while they are doing the surgery? We all know that the most common method by which the COVID-19 virus transmits from one person to another is by aerosols. So any aerosol generating procedure is a risk uh, for the surgeons or the anesthetists who are taking care of the patient. And all surgeries are inherently aerosol generating procedures because it entails intubation and throat suctioning and other things. Urological societies have come out and told that urine spillage and aerosolization during cystoscopies can also transmit the virus, and the virus is also demonstrated in feces. So colonoscopy and GI procedures are also a risk for aerosol transmission. Now, is there a role for blood-borne transmission like a hepatitis viral transmission? There is no documented blood-borne transmission of COVID-19 virus yet. However, the European Center for Disease Control have advised that there should be no blood donation for 21 days after exposure or documented infection from a patient with the COVID-19. So, another aspect of COVID-19 transmission during surgery is the risk of virus that is spread through the surgical smoke. So this has been a widely discussed topic for the last 4 or 5 months. We all know that the size of the COVID-19 virus is somewhere around zero point 0.1 micron. The range is from 0.06 to 0.014 microns. And during surgeries, we use a lot of energy equipment for our surgery, like electrocautery, lasers, and harmonic. So during all this, small microscopic smoke particles are generated, and the size is somewhere between 0.07 microns to up to 6 microns when it comes to harmonic. So COVID-19 virus can be carried in the surgical smoke plume. However, the risk of transmission through this has not been documented yet. So that we have to have in mind. Why it all came into picture is in patients who undergo papilloma excision due to human papilloma virus, there have been documented transmission to healthcare workers during usage of electrocautery and other equipments. So similarly, can COVID-19 virus be suspended in the smoke particles and be transmitted to the surgeon? There is a possibility scientifically and theoretically. However, from a practical standpoint, no cases have been documented as yet. Other aspect is the release of pressurized gas during laparoscopy. We will address this particular situation in the subsequent slides. Now, is there a way to evacuate the surgical smokes safely? Yes, there are several equipments that have recently reached the market from various companies like ConMed, Ethicon, Stryker, and all. And there have been studies to compare the efficacy of all these. So it is basically individual surgeon's choice to prefer or buy any of those equipments. Now, what is the role of PPE during surgery? According to the British Society, the full PPE has to be worn during a aerosol generating procedure in any patient. And how have they defined full PPE is wearing a respirator mask, the N99 or full face piece particulate type 3 respirator, and there should be a fluid repellent long gown, and there should be full face shield with a visor, and surgeons should wear double gloves. So this is the definition of full PPE in a patient who is going to undergo aerosol generating procedure. So according to this British guidelines, there is no jumpsuit that is prescribed. However, in the Indian context, where the jumpsuit type of PPE is widely available and it is being worn wherever we do a aerosol generating procedure, I think that holds good um, for procedures like general surgical procedures as well. And is there a difference between the masks, how a routine surgical mask is better or less better compared to a N95 or a N99 mask? See, practically speaking, N95 mask is presently widely available and appears to be sufficient. So, coming to the third aspect of discussion, what are the changes in OT setup and protocols that we have to follow during COVID-19 pandemic? First and foremost, there should be excellent theater discipline. This is a cornerstone when it comes to prevention of viral transmission. Use of checklist is mandatory because you see inside the theater lot almost all of them are in full PPE, and the communication is difficult unlike the pre-COVID period. So checklist is going to be handy in preventing surgical errors, and there should be enough number of theaters. So this is something the administration of the hospital should look at, because they should allow sufficient downtime between surgeries to ensure full decontamination. Previously, we used to run surgeries one followed by the other, but now we have to give time for full decontamination of the theater between surgeries. So, for that, we have to have enough number of theaters. Whether we should have a designated OT for COVID-19 patients, yes, this is absolutely essential. In hospital setups which has multiple operation theaters, a specific theater should be earmarked for COVID-19 patients, and in that theater there should be a planned patient movement. The coming in and going out should be very much planned, and the flow of theater staff should be mapped. It is better to allow minimum number of staff inside the theater, and it is better to have minimum equipment inside COVID theaters, and we should minimize the number of entries inside the operation theater. So coming to which operation theater should we put to use for COVID-19 patient? A operation theater which has negative pressure ventilation is probably the best when it comes to operating on COVID-19 patient. However, negative pressure theaters are not very common even in large hospitals. But we have what is called the positive pressure ventilated theaters. So this can be used, but the guideline says that it has to be stopped during the procedure and for 20 minutes after the patient leaves the room. So the positive pressure ventilation should be stopped during the procedure and for 20 minutes after the patient leaves the room. So these are the guidelines put forth by the occupational safety group, that positive pressure ventilated theaters can also be used. And laminar airflow theaters are really good when it comes to operating on COVID-19 patient, because laminar airflow provides unidirectional airflow, and there is continuous flow of highly filtered air in a single direction, and it has been shown that it has near 100% efficacy in removing airborne particles of zero point 0.3 microns and larger. Now, another advantage is in laminar airflow theaters, the smoke, surgical smoke, will be pushed to the floor and the inhalation risk is diminished. So, this is another advantage. So, coming to a laparoscopy in COVID-19 era, there have been several discussions and webinars on the role of minimal invasive surgery in COVID-19 era. The problem that was perceived initially was, when we use pneumoperitoneum for laparoscopy, whether the pneumoperitoneum can carry virus particles and transmit to the surgeons and the healthcare workers. It has been shown that COVID-19 virus can be shed from the peritoneum. So theoretically, yes, there is definitely a risk of COVID-19 transmission from pneumoperitoneum. So, but practically there is no sufficient evidence as yet that COVID-19 transmission can happen during a laparoscopic procedure. However, precautions are mandatory. There are several changes in the techniques of laparoscopy that has been advocated by the minimal invasive surgical community. Like we can use alternative first entry techniques, we can use a Veris needle technique rather than a direct open technique, whereby the gas leak is minimized. We can use what is called the balloon secured trocar, so that the gas leak along the trocar can be minimized, and we can try controlled evacuation of pneumoperitoneum, whereby the pneumoperitoneum is evacuated into a solution containing hypochlorite or any other virucidal solution. That also reduces the transmission. So these are all the things that we can use to prevent COVID-19 transmission during laparoscopy, and worldwide it has been proposed that laparoscopy can be safely carried out during COVID-19 pandemic. Coming to the fourth part of discussion, what is the role of preoperative COVID-19 screening? So, how do we screen patients when they come for elective surgery? So, what is usually done is screening with a questionnaire. The questionnaire will have the travel history, symptom history, and any contact history. Throat swab for COVID-19 PCR, preferably done within 72 hours of surgery. However, it has been found that throat swab is only 71% sensitive in diagnosing COVID-19. Most important is to do a CT scan of the chest, which is found to be 97% sensitive in diagnosing COVID-19 infection. So, in our institution, both throat swab and chest CT is done prior to elective surgery. preferably isolated for 14 days before the elective surgery. That is also preferable when patients undergo major surgeries, especially transplant surgeries, where the recipients are going to be immunosuppressed after the transplant, and mm, if they have a post transplant COVID-19 infection, they might have a increased risk of mortality due to COVID-19 pneumonia. So they can be isolated 14 days prior to the date of planned surgery, and it is mandatory that they undergo surgery in a COVID cold site. And to create a COVID cold site within the hospital is definitely in the purview of the administrative part of the hospital. So, in when the patient undergo acute care or an emergency surgery, what are the protocols? So, if we have a COVID-19 status that is unknown, patients, to do RT-PCR is going to be time consuming. The minimum turnaround time for RT-PCR is around 6 hours. It can be plus or minus 2 hours depending on the setup of the hospital. But in general, it is going to take time for us to get the report within 6 hours. So, what is the role of rapid antigen detecting methods? Now we see that these kits are slowly becoming available. Even in India, we are seeing that this kit might be coming for bedside use within probably a month or so. So, that will be quite handy, where you can take a specimen and in the bedside you can assess whether there is antigen positivity for COVID-19 RNA. Until it becomes available, the best and the most advocated form of screening is to have a CT chest. So, CT chest for any emergency surgery patient appears to be mandatory. If the patient undergoes any other emergency surgery like abdominal surgery, and if the patient has a need to go to the CT room, for example, a CT brain before a neurosurgery or a CT abdomen before a GI surgery, then it is mandatory to include a CT chest for as a part of their preoperative screening. And it goes without saying that full PPE is essential for all the team members involved in the emergency care of a COVID status unknown patients. So the second part of this discussion will be when to operate for a COVID positive patient. Now, when to offer elective surgery for a patient who has recovered from COVID. Now I see situations where, now that we are in the declining trend of the COVID 19 pandemic, we are seeing several patients who got recovered from COVID approaching us for elective surgeries like a cholecystectomy, like a appendicectomy, like a hernia repair. And there are situations where if the patient had an acute cholecystitis along with the COVID, they have been conservatively managed. Now that they have cleared the virus, they are coming back for their delayed cholecystectomy and things, and interval appendicectomy and surgeries like that. So when to offer surgery on these patients? The Center for Disease Control and the American Society of Anesthesiologists, they have come out with guidelines that mm, there should be resolution of fever without the use of any antipyretic medications. That is point number one. And there should be improvement in respiratory symptoms, and the patient should have negative results, at least two antigen tests, that is throat swab for COVID-19 PCR, more than 24 hours. So these three things are mandatory, that the patient should not have fever, the patient should not have severe respiratory symptoms, and the patient should have two uh, negative throat swab PCR reports. So when these criteria are met, then the patient can safely undergo a delayed elective operation. In situations where we cannot do repeated throat swabs due to lesser availability or non-availability of tests, CDC has come out with a non-test based strategy where we can take patients even without a negative PCR. So the criteria that was set forth was there should be at least 72 hours since the resolution of fever, and there should be no further episodes of fever without the use of antipyretics, and it should be at least 10 days since the appearance of first COVID symptom. So these are the criteria that should be met before we offer surgery without a throat swab. So, a test-based strategy where we do two throat swabs or a non-test-based strategy can be used to offer elective surgery to a COVID-19 patient. Now, what is the role for antibody testing in COVID patients? Now, I get calls from hospitals that COVID is negative, but when I go and see, it is actually the antibody, rapid antibody that is negative. So, we have to understand that there is no role for antibody when we do a preoperative screening, because antibody develop in the second week of symptoms. So it takes 1 week for the patient to mount an antibody response to a COVID-19 viral exposure. So if we are going to see the patient with in the first week, then antibody testing is not going to be positive, and we can still end up operating on a COVID-19 positive patient. Second, many patients do not even develop detectable antibodies. So that is another thing that we have to have in mind. And the patients who develop antibodies can rapidly have a very undetectable levels of antibodies within few weeks or so. So antibody testing is generally not reliable when it comes to diagnosis or screening of COVID-19 patients. And thirdly, antibody tests can cross react with other respiratory coronaviruses. So there can be false positivity also with the antibody test. So to summarize, COVID antibody testing as a preoperative screening is not advocated as of now. So coming to the last part of the discussion, is there a change in the post-operative care when a patient undergo a surgery during the COVID-19 pandemic? Yes, definitely there is a mm, there COVID-19 has impacted the post-operative care as well. The thing that we have to understand is there can be exposure during the hospital stay, during the postoperative period. Then cytokine and immunosuppressive response to major surgery is a natural phenomenon, and we all know that a patient with COVID-19 can have a severe COVID-19 pneumonia due to cytokine storm, so which can occur in a normal post-operative patient. So this can pave way for a very severe COVID-19 infection in the post-operative period, and few patients who undergo surgery are going to be mechanically ventilated also. So, and again, this can be an impact in managing COVID-19 pneumonia in the post-operative period. So, all these things has to be kept in mind, that a post-operative patient is at a higher risk of COVID-19 infection and associated morbidity and mortality. So that has to be borne in mind. So this was so what is the risk that the COVID-19 patients have during surgery? That was addressed in an international multi-center study that was recently published in the Lancet. So it included 235 hospitals from 24 countries with more than 1,000 patients. All of these patients were COVID positive, and three-fourths of the patient underwent emergency surgery, and this comes through a collaborative called COVID Surge, which is a multinational collaborative. So what it has found is a patient who undergoes surgery who is a COVID positive patient has a very high mortality of up to 24% 30-day mortality. So this is something that really has to be thought before offering a surgery, and they have 51% risk of post-operative pulmonary complications. So imagine a patient who undergoes surgery, like an emergency appendectomy, and he is a COVID positive patient. The mortality rate is somewhere around 24%, which is very high compared to the non-COVID era. And there are several risk factors that have been found as well, namely the male sex and elderly people who are more than 70 years of age, higher ASA grades like grade 3 to 5, a patient who has cancer, a patient who has emergency surgery, a patient who has undergone major surgery. So these are all the risk factors that are really putting them at risk. So the study concluded that post-operative complications and mortality is higher than in the pre-COVID era. Surgery should be postponed and non-operative management should be used whenever possible. So that is the recommendation coming out from the study. So this is an important study that the surgeons have to take note of. So, what what idea it has given to the surgeons that how to look at surgical practice during COVID-19 outbreaks is that if the surgery is non-critical, it is better to postpone. Now that we know the mortality is quite high if the patient is found to be COVID positive because of the study that was published in Lancet, then if there are ways to promote non-operative management, it is better to do so. For example, if the patient has a simple appendicitis without any abscess, maybe we should try medical management. And I have personally used medical management for acute cholecystitis if the patient has non-critical and if the patient doesn't have an empyema or a ruptured gallbladder. So whenever possible, try non-operative management. All this will help in minimizing the in-hospital viral transmission and to prevent bad post-operative outcome due to COVID-19, routine pre-operative screening is mandatory. We should not lax our guidelines on this. If we are going to do surgery, it is mandatory to do pre-operative screening. And finally, all these things will definitely help us in mitigating the risk of post-operative pulmonary complication, and we should be communicating with the anesthetist, critical care team and pulmonologist to find out ways where we can mitigate the risk of post-operative pulmonary complications. It has been known that any COVID positive patient who gets ventilated, it is very difficult for the intensive care personnel to wean them off from ventilator. So we should try our best to not to put the patient on a mechanical ventilation. So these are all the things that has to be discussed as a multidisciplinary decision making, and then the surgery should be planned for the patient. So to conclude, dear friends, it is an urgent requirement for surgeons during the COVID-19 pandemic to balance their workload, to take sensible precautions, thereby they protect themselves, their team members and their patients. So surgeons have to be sensible and sensitive enough to take the right decisions during this unprecedented pandemic. In the end, the objective is to reduce the overall mortality and morbidity of the patient, of the surgical patient who undergoes surgery, and the health and efficiency of the team members has to be preserved. So thus we have to take care in a positive manner, and I can definitely tell that in the past 6 months the surgical community has done remarkably well in handling the pandemic. They have lent their support to the non-surgical colleagues, and they have tried their best to offer emergency surgical services to the patients who are in need of emergency surgical services. And now we are, at least in India, we are seeing the activity of non-emergency surgeries, essential surgeries like onco surgeries and transplant surgeries are slowly uh, coming up to the pre-COVID days. So we have to thank the surgical community altogether for handling the pandemic situation quite well. Thank you, dear friends. Kindly subscribe to our YouTube channel, Dr. Madhu Surgical Classroom, and kindly mail us for any queries. Thank you very much.